Welcome back, everybody, to Through Help and Back podcast. This is a podcast focused on mental health issues related to personal health, mental health, addiction, but always with a positive spin, always looking for solutions, always looking to give you guys some answers. We hope after you're done listening, life is 1% better than before you started. So we have a very special guest.
You changed the name.
Well, it started as the difference that makes a difference.
That's what I remember.
That's what it started. We talked about that last time.
But we said that was grandiose, I guess.
It was just such a mouthful. Just like, I still believe in that. And the last episode we talked about, like with solution-focused therapy, you're always looking for the difference that makes a difference. But I mean, how do you put a website together with that? And people, it's just pronunciation and spelling. And
so am I a co-host, or have I been demoted to a special guest?
No, I said special guest.
Okay, it's
cool. Your first one.
Not, it's cool.
No demotion for sure.
No, I'm not offended at all.
I wouldn't say demotion. This is your first Through Help and Back, though, right?
Yeah, that's true.
This is your first Through Help and Back. So
first of many, though. Well, how often are you going to do this?
I mean,
are you doing this weekly?
Once a week. Yeah.
Okay.
Yeah, once a week. So
I guess I'll be here. Okay, so every other session. So I'm a.
Yeah, you're a regular contributor. A regular contributor.
Regular contributor.
Co-host is good. I mean, featured contributor.
Featured. It should be something special.
It should be something special. So for those watching and like, who is this special person? We need a special name for. Last time, actually, you missed this. We were live. So Heather Perry was with us, and we were live on her TikTok.
Oh,
and so we got real feedback in real time.
Wow.
They could have given you a title, like right there on the spot.
So people were watching.
And commenting.
Wow.
Some nice things.
Some not so nice things.
Some other things.
Like,
Get the camera off this guy. But it was fun. Yeah, like 1,500 people.
Really?
Yeah, it's a big deal.
Okay.
It's almost.
And what's a big deal in this industry? What do we need here to make a difference? Only one person.
One life.
One life.
If only one life is changed. But I'd like to have 5,000 people in that episode, right? Like, why not?
Yeah, of course.
And when you look at the numbers, and we're going to talk a little bit about that here in a second, about the number of people affected by mental illness.
Big numbers, yeah.
Or in their family. I mean, you're talking, 1 in 5. Right? Is that the latest number they've thrown around, where it's like 1 in 5 people are directly affected? Now throw in family members and everything like that. But this is Dr. Michael Boggs, for those watching at home and wondering who the special guest is. He's the Chief Medical Officer of 𝐬𝐻 Behavioral Health and amongst other things. And we were chatting before we went live, because producer Ian was making everything perfect. He lets good be the enemy of perfect. He needs to be perfect. So he was lining us up.
That's all right. That's what
we missed. And Dr. Boggs is coming fresh off some live sessions this morning. So you've been seeing patients all day.
And we were musing on, because this was I've been seeing patients with 𝐬𝐻 myself for 18 months about, this was actually the first day I was back in the office. So, kind of seeing people in person and just talking a little bit about how, telemedicine's been really helpful. I think it's been a needed intervention during the pandemic, which we talked about, how there has been a pandemic, and but it is a little different getting to see people in person. It's a little better. I think the connections are a little deeper. There's a little more communication that happens in terms of body language and handshake.
You saw people obviously before. How long have you been practicing? How long have you been a psychiatrist and actually in active practice?
Be 6 years.
6 years? Okay. So you had at least a base of 3-4 years there where you were all in person.
That's right.
Telehealth was like
I wasn't doing telehealth. Yeah. I wasn't doing telehealth before.
And then the pandemic hits.
Yeah.
And then it's a little bit of both and both, but then everybody gets scared, and then pretty much really fast it felt like 100%
we were like just telehealth. But it'll be interesting in mental health, because I think we're particularly well suited to do a pretty good job through telemedicine. I think probably for some people, for a lot of people, it's probably just as good or good enough. But it is a little different.
Now, when you say that in behavioral health, we're particularly suited to do a good job in that format, what do you think makes us particularly suited to be able to meet needs even on a phone call or via video chat?
Yeah, well, I think via video chat in particular, being better than the phone, which is still better than nothing. We do focus on people and their stories and talking about how they're feeling and how they're doing and their subjective experience, and we don't rely at this point in time on the physical exam for or minimal need for physical exam in mental health care. A little bit. I don't want to say no. There's in case there's a older psychiatrist listening in. It's not like there's none, but not much. Mainly it's talking with people. And
right. And so some people will get caught up in like the terminology. So for a psychiatrist like yourself,
yep.
versus a psychiatrist, versus a psychologist, or versus a counselor, the role of like in person for a psychiatrist, like what's important about that for you? What do you feel like you lose if they're not in the room? Because theoretically, right, like you think psychiatry is more about the prescription, diagnosis, psychopharmacology. Like theoretically, you could have a list of symptoms.
Theoretically, it should be just as good, but it is a little different in terms of the connection. Attachment and interpersonal connection is really important, and we can sometimes connect with people and get a bond between two humans a little faster in an in-person setting, and sometimes you can connect with people in a in-person setting better than through a screen.
Right.
So it's not quite the same. So there is some value added to physically being in the same space.
Just human factors, right? Just human stuff, right? Like theoretically, I could put my likes and dislikes on a screen. You could put yours on, and we could make a perfect match dating. But there's just something to the interaction and how you like get along.
About how in person this is true love,
right? Or sometimes the math doesn't work out.
Yeah,
you like dogs, I like dogs, but I don't like being around you.
Yeah. Different types of dogs.
True.
But so it's a little different, but it felt good to go in and actually get to see people and shake some hands. And
I think it's great. When we first came to this area, so, 𝐬𝐬 has quite a few locations in Ohio, a little bit less so in New Hampshire, but catching up. I mean, you look at the numbers, New Hampshire's catching up, which is funny for a smaller state, but just the need is incredible. And I can remember, day one in the office where it's like myself and a care coordinator, and that's it. And then fast forward, to a couple weeks ago, we had like 4 therapists in person at the same time, and the place was like alive and felt like the old career, because I was all in person myself as a therapist, and boy, it's awesome. It's awesome to feel that and see that and watch that growth. And now you're back in person.
The energy's a little different. The felt sense of what's going on is a little different, and it's meaningful.
Yeah, absolutely. And I think the therapists have responded, and they're enjoying.
Yeah.
That everybody's getting the vaccinations, those who want to, and everybody's feeling safer. And if there's treatment protocols in place, and we're not going to get too scared of monkeypox, and we're just going to try to live our life and see people, So. Yeah,
I agree. But so back in the office, making things real, and then I think that in addition to kind of musing on the in-person connections and the value of that, I think we were going to talk a little bit about. I think you wanted to talk about depression, or maybe an antidepressant medication. And just pointing out that there's quite a few people that take antidepressant medications, quite a few people that benefit a lot, and quite a few people that benefit some, and quite a few people that are not benefiting that much.
Right. Well, and that's the goal, right? To borrow your expertise and to be here in person and talk about that, because, as a therapist, certainly a lot of encounters with antidepressant, anti-anxiety medication, things like that, psychotropic medications, but that's your training, and that's your whole world. And so I guess just to lay kind of a framework for people who are listening who haven't worked in the field, when you hear like antidepressant versus, anti-anxiety or psych meds, just hear this like broad term. Can you talk a little bit about kind of like those divisions? Because I'd like to talk about antidepressants today. So can you talk a little bit about like what an antidepressant is and how that differs from some of the other psychotropic medication options that are out there?
Sure. So I think broadly speaking, when we say antidepressant, we tend to be talking about medications that have been FDA approved for major depressive disorder or other depressive illnesses. We can talk at another session about the differential between bipolar spectrum illnesses versus major depressive disorder, versus post-traumatic stress disorder, versus there's different ways people can be feeling sad right now, persistently sad, low energy, low motivation, feeling bleak, sometimes having thoughts of suicide or wishing they weren't around. That can be connected to different things, but if we say we're talking about depression, and then say we're talking about major depressive illness, separate from bipolar disorder, which sometimes there's little bits of overlap with a lot of these different diagnoses, but if we just say depression and severe depression being a persistently low mood state with neurovegetative symptoms, feeling tired and low energy, poor appetite, poor sleep, that depressive illness and severe depression has been seen and recognized for thousands of years in human history, well established as a thing that people have struggled with. And one of the primary ways that we will go about treating that now is with antidepressant medications. We can look at, kind of broadly speaking, we could look at there being medications. We can look at there being life and what you do in your life and what your behaviors are, and health promoting and health detracting that contribute to being depressed or contribute to feeling good. And then we have psychotherapy, which is another modality of helping people through talk, better understand what's happening with them, and better figure out how to navigate their own minds, how they can think about things differently and process things differently to help over time not feel depressed. And I think all three of those are important and overlapping, and a lot of people will see a psychiatrist or a family doctor or other, or nurse practitioner, and be prescribed an antidepressant medication, which we could say is a medication designed to help them feel better. There's different types of medication that we can use to try to help with depression. There's probably different kinds of depression. The most commonly prescribed ones are the SSRIs, so that'd be like Prozac or Lexapro, Zoloft, and these are selective serotonin reuptake inhibitors. There are differences with the different SSRIs and SNRIs. SNRIs, it's a norepinephrine reuptake inhibitor as well as serotonin. But if we look at the SSRIs as your core kind of antidepressant, when people are talking about antidepressants, they can say, well, what is that? What is that doing? And as best we know, the mechanism of action of those medicines, so what they're doing in your brain is they are inhibiting the reuptake of serotonin in the middle part of your brain. In the limbic system is the emotional structures of your brain. The limbic system, the brainstem, is deeper emotional structures. And we can talk more about emotion and stuff, but from a scientific standpoint, this seems like this is the same kind of emotions that animals will feel, that dogs will feel, cats will feel, horses will feel. And if that gets, some of those emotional networks get set on too much on in a negative way on. So if it's grief or sadness, structures of kind of that emotional core that's overactive for that person, one of the things you can do is you can increase the amount of serotonin in the brain synapses, and that actually has an inhibitory effect on those emotional networks, which means that if you inhibit sadness, someone will hopefully feel less sad. If that's what if that is the driver of this, the depressive syndrome. So if what we're looking at is depression and we think that it's due to that hyperactive emotional network, you can calm it down with serotonin. And so that's what we're doing with SSRIs, is it's like, I think they're really cool. I prescribe them a lot. They can help a lot of people. Yeah. So I don't want to sound it like a negative thing, but in some ways they're like a mid-brain sedative.
That's interesting. So as we conceptualize this and just kind of think about it, if I'm somebody who has been prescribed that, it's not that it's going to make me happy. It's going to make me less sad, thereby creating room for comfort and happy to develop. Yeah.
Well, one of the core either emotion networks or basic drive is called the seeking system. That's like kind of like your Now, so another way people could feel depressed is if their seeking system is depressed, so they're lacking of energy, and that could be why when people are sick, typically when they get older, but it could be at any age if they're feeling depressed, but more primarily due to low energy, feeling sick, feeling run down, they can have a depressive syndrome in a hospital or elsewhere that's not necessarily very responsive to antidepressants, because their issue is not that their sadness network is overactive. Their issue is that their drive network that's giving them the kind of the get up and go and feeling that zest for life and enthusiasm is depressed due to their illness. And that is why people with that depressive syndrome through more medical illness tend to respond really well to psychostimulants. So they would respond well to a stimulant for their depressive syndrome, because that would then give them more energy, more dopamine, more norepinephrine that will help give them energy, and then they'll feel better because that's actually the mechanism via which they're feeling depressed. Whereas a lot of people with more classic depression have a hyperactivity of that kind of sadness emotional network. And so, and that's why if you get somebody who doesn't have any medical issues and they're not having issues necessarily intrinsically with their driver motivational system, and if you give them a stimulant, they won't feel less depressed. They'll feel a little more energized, they'll be better able to focus, but they don't feel less depressed, which is why when we study stimulants, psychostimulants for classic depression, there's a minimal benefit for a lot of people with this more classical depressive symptoms. Some people benefit a little. Some people, they can use the energy from the stimulant to better engage with their therapist, to better figure out what's going on, to better change things in their life and move forward, and their depression can improve that way. But the core symptoms of the depression are not improved by the stimulant.
Now, is there, when you say stimulant, so is that the SNRI you're talking about? Or is that a separate
So a stimulant would be a different category. That would be like an Adderall, or a Ritalin,
a full-on,
a medicine that we typically prescribe primarily for ADHD, but which will be prescribed off-label for depression in some cases, and will certainly be prescribed quite a lot in consultation liaison psychiatry in people who are ill in the hospital and feeling really worn down and sad as a result of their illness.
And that's just to bring that drive, that compulsion to get you moving. That's right. So to speak, not even about a focus. So when you say off-label, can you talk a little bit about that? Because I know that's used a lot. Like, so my basic understanding of that is like not every medication is currently used for the thing it was originally developed for. Is that kind of the best understanding?
Yeah, on-label would mean that it is approved by the federal FDA, Federal Drug Administration. They will give approvals for certain indications for medication. So on-label would mean it's FDA approved for such and such. So it was approved for major depressive disorder. So like the antidepressants, like the Zoloft, Prozac, Paxil.
We know it works for this. We designed it to work for that.
Yes.
Sort of.
Again, being a little more nuanced, right? Because it depends on why somebody's feeling depressed. But in that classic depressive symptom, and there have been studies with the medications on people in these categories, and if there's enough evidence to support it, the FDA will approve it for that indication. But it's a whole process, and so sometimes things get used off-label, which means that a doctor or other prescriber is prescribing them to you to help you with something, but it doesn't have a FDA approval for that indication. Another example of that might be for the person, and it can get more confused with a lot of times the antidepressants, because they're kind of like a midbrain sedative of sorts. They're kind of calming down. So what that would mean is that the top part of your brain is the thinking part. They don't interact that much with the cerebral cortex. So they can calm down the middle part of your brain without making you tired or without slowing down your thinking process. But we will also use those antidepressants first line for anxiety disorders. Gotcha. And a lot of times people will say, well, no, I'm anxious. Why are you prescribing me Prozac? Or why are you prescribing me Zoloft or Lexapro? I'm not depressed. I'm just really anxious. Well, because in that same kind of emotional, there's a different emotional structure for fear and anxiety, as well as you can get anxious feelings through that kind of sadness, kind of grief, kind of emotional network as well too, can also manifest as anxiety. And the SSRI, by increasing the amount of serotonin there, calms down those networks and helps people feel a lot less anxious. And actually, the effect size for anxiety disorders tends to be better for antidepressants than for depression overall, meaning they work even better for anxiety than they do for depression. But
because of that sedative effect.
Yeah, that same effect.
So, and I don't want to scare anybody off. And it's funny because a lot of this I'm familiar with, but a lot of it I'm kind of hearing for the first time too. And some people may pick up on it, but so, and I know this is a very off-label prescribing is a very common practice. This is not something that, Dr. Boggs has found a loophole, right? No. But people are receiving medications that are not FDA approved for their specific diagnosis. But as doctors, you have the ability to sort of step outside
sometimes.
that.
But also, a lot of the SSRIs are FDA approved for anxiety.
Okay, could be both.
It could be both, but people call them colloquially antidepressants.
Yeah, right.
So they'd say, well, why are you prescribing me an antidepressant for my anxiety?
Gotcha.
Because of the properties of how it's working. And then the FDA has seen that there's a lot of data for the SSRIs. So it actually, a bunch of the different SSRIs are FDA approved for treating anxiety disorders. Right. So it's actually not off-label. It's just kind of falls under that where people are like, well, why are you prescribing me this? Yeah, it works. And
it works. So we found it works. Yeah, that's either by accident or otherwise we found it works.
And then for depression, but for in the bigger studies we've done in looking at the I forget the name of some of the bigger, but some of the bigger studies we've done in looking at antidepressants. If you look at Lexapro, and you give it to somebody who's depressed, this will break down that meets the criteria for major depressive disorder. Again, this is separate from what's actually underlying the neurochemistry of their individual depression. But if they meet this criteria for being in a depressive episode, about 1/3 of people, if they're on an SSRI like Lexapro for 4 to 6 weeks, will go into full-on remission, meaning they will go from profoundly depressed to not feeling depressed at all and feeling well, taking the antidepressant medication. So that's about 1/3. So for about 1/3 of people, it does almost seem like a magical medication. I know we talked about that. We're not into magic pills or having it be like, oh, this is everything, because there's all these other spectrums of life and other spectrums of treatment. But for about 1/3 of people, they functionally do work as sort of a magic pill for that person. Obviously, it's not permanent. For some people, there can be side effects. So like it's not, so it's not magic. But for about 1/3 of people, that's pretty good. You go from like feeling like total crap to
if you're one of those 33%.
If you're one of those 33%,
life is totally different.
To feeling totally better. And then for about 1/3 of people, they have a moderate reduction in symptoms. So they notice like it definitely helps, but they're definitely still depressed. And then for about 1/3 of people, they get really minimal benefit from the classic antidepressant medication.
So backing up a little bit when you talk about, and I'll mangle all these terms, but
totally fine.
When you're talking about the an overdrive of the sadness component, right?
Yeah.
The depressive component is an overdrive versus a depressed drive or a depressed motivation component. Yeah. You say, well, sometimes it can be this, sometimes it can be that. How can, and this is where I think that medicine in general, sometimes, especially when it's newer, has a little bit of a mystical kind of aura to it. Like, how could you know that, right? You know what I mean? Versus like a broken bone,
right?
Where like I look at an x-ray. So when you're working as a psychiatrist and you're working with somebody brand new, you've got their history, you've got their background, but how do you know if it's A versus B? How do I know sitting there or determine that this is a person who probably has a depressed drive versus an overactive depressive system? How do you make that?
I think that usually you end up needing to try things. You come up with a hypothesis, and this is where people, if it works well, it's not that big a deal. Maybe you try one thing, maybe you try a couple of medicines, and then you find one that works well for you and it's good. But where it can get really frustrating for people is if they have to try medicine after medicine after medicine to get relief. To some degree, you can try to sort it out through your interview. You can try to get at what their symptoms are, what the time course of it is. There probably are certain. There are probably some therapists, some psychiatrists that would say, "Oh, I can figure it out based on my interview or based on my intuition." I think that probably a lot of times we don't know, and so we will often try something and see what the response is. And so usually you'll try something. So if somebody's depressed and they are interested in trying an antidepressant, you'll talk them through the risk, benefits, and side effects, give it a try, and then you monitor what the response is. And you'll see if they are going to fall into that bucket of the first third of people who, boy, they're much better quite quickly versus the third bucket of, well, because the other thing is there's a fair amount of people could say it's both. They have a depressed drive and their sadness is hyperactive, and even then I should be careful because there's some people say, well, it's not necessarily for some people. It might not actually be hyperactive. It's just they're sensitive to it, so their sadness system is more than they can tolerate, and they get burnt down. So it gets more nuanced. But then you try and see, and if you get some benefit, then you can often say, okay, well you talk with them about it. Is it worth it to you? Are you getting any side effects? Are you having a bad thing? Or is it just somewhat helpful? And if it's just somewhat helpful, then often you'll say, okay, well, we can stick with that and then talk about either switching to something different or adding something else in. One of the things that we will, with the new, and in general in our field, we will almost always recommend psychotherapy as well as the medication concurrently. Which is another thing that's like broadly really helpful, and a lot of different psychotherapeutic interventions can be helpful and have some evidence base for different mental health conditions. Kind of like medications, there's a lot of different kinds of therapies. There's a lot of different ways people do therapy, and some probably work a lot better than others, but we haven't yet done a great job figuring out exactly which works the best and which will work the best for whom. And so therapy tends to fall into the same kind of category of medication where you try something, you try a given approach, and oftentimes it will be helpful, and other times it will be sometimes it'll be very helpful, sometimes it will be somewhat helpful, and sometimes it won't be helpful at all. And then that's the whole niche of the psychotherapist or the psychiatrist, if they're doing psychotherapy on a regular basis, where they then have to make a determination, is this working or is this not working? And if it's not working, when do we switch? I think, we ran into that with psychotherapy, with kind of classic psychoanalysis, where for some people it worked very well. Sure. So we've maligned it because there are a lot of people for whom it didn't work very well. And then we'd say, all right, well, we'd still like you to keep coming back a couple times a week and lay on the couch and pay money for that service. When, for a percentage of people, that's really not what's going to help them. Right. But for some people, it does. But I think that's where then there has to be some agility with kind of changing to different modalities among, in the same way that you try a different medication, that you try a different style or different modality of psychotherapy. And then overlaying all of this is people's positive or negative expectancy about coming into treatment, which is a kind of fancy way of saying kind of like the placebo effect, but not, I don't mean it's it in a nasty way.
More likely to work if you believe it's going to work?
For a little bit.
Yeah, at first. And
then it depends, because if that initial positive expectancy gives you enough of a boost that you change enough other things in your life. Right. So if that boost of positive expectancy is enough to go from laying in your bed all day feeling bad to
I'm on my antidepressant, so I can move now. I'm
getting
get
out,
up.
going out with your family, going out with friends, re-engaging in physical activity, fully getting back in your life, then,
And then those benefits
and at that point,
up.
it's not right. But then it's not always that clear, right? What worked,
right?
Because and then the rough and dirty would be that probably the first couple weeks to a month you can't really know for sure what is driving the benefit, or Likewise, you can get people that have been through treatment a bunch of times if they haven't had good experiences. So say they're in the third of people that don't get any benefit from the first couple of antidepressants that they try. They have a couple of therapists that they meet with that they don't click with. They don't connect well with them. They feel triggered, whatever. It's not a good system for them. Then they might continue to engage in treatment because family and friends and other people say you really need to be in treatment. But their mentality coming into it is this isn't going to work. So then they have a negative expectancy. Sometimes people can come into it with a negative expectancy saying this medication isn't going to work at all. But if they take it, if they actually take it anyways for a month, they'll actually start to feel better because it actually is working, but then they don't get any of that positive expectancy of like kind of expecting it to work and then mobilizing their own resources. And so that just adds another layer of complexity on top of it. But I think kind of peeling back down to it, treatment in its different manifestations does work fairly well for most people over time. And so I would say regardless of the specifics of it, it is often at least fairly helpful, both medications and therapy. And oftentimes, if you stick with it and you're willing to do the work, it's very helpful for most people. Not all, but most people get a tremendous amount of benefit over time. And so that's why kind of getting into the weeds, I don't want to get away from the idea that the most important thing is access, get people into help. Get them into therapy first, and then we can start to answer questions about, is this the right therapist for them? Is this the right kind of therapy for them?
So there's a little trust the process that goes into this for a client because
there is.
And full disclosure, obviously I work with 𝐬𝐬 and I'm giving you a lot of the pushback that my clients have given me over the years.
Of course.
They'll go to the psychiatrist and they'll come back and say, well, it's a month later, this crap doesn't work, or it's 2 days later, I don't feel all better. So there's this stuff isn't happening. And I think there's like this desire. We talked on the last episode about how a lot of therapy is more art than science, but we try to do like the science-ification of it where we want to measure everything and know exactly, like as if there was this sheet that if you say these 10 things to somebody, they're going to feel happier 70% of the time, and it just doesn't exist.
No, not yet. And but I'd say that I think it's both art and science rather than either or, and it's just the science is still being developed.
Gotcha.
Right. So I think some of the art is given all those uncertainties, applying it based on your experience as a therapist or your experience as a psychopharmacologist, working to help this individual that's in front of you for treatment. And you want it to be guided by science to the degree you can, but there is a lot of stuff that is not yet mapped out in terms of the science. The human brain is unbelievably complex, like so complex. It's amazing. We're talking
almost as good as my iPhone.
I know.
That's crazy.
I forget if it's millions or billions, but it's millions or billions of neurons, each with thousands of different connections with other neurons. So that they change.
Always.
So the complexity of this system is awesome, and the science is evolving.
And what matters? It doesn't matter that it works. It doesn't matter that you know exactly how it works. Right? Like I know working out can make me in better shape. I don't know,
exactly.
I don't know how the lipids are activated to mobilize and shrug off my body when it works. I just know if I go to the gym and I work out, I feel pretty good. And over time, if I contribute those positive things, I'll look better and I'll feel better. I don't really need to know the Krebs cycle and how my food is digested exactly and turned into energy.
Yeah, don't ask me how to define the Krebs cycle anymore. I don't really remember how
it chased me out of exercise physiology.
I don't remember how to define that.
Scarred by that.
No, but sure. And you could look at exercise as another thing that's probably similar, right? Where like probably over time we're going to learn there's certain kinds of exercise that genuinely are better for your long-term health. But we know that exercise of any kind is at least on the whole fairly helpful.
Certainly
maybe
better
even
than
very
home.
helpful. Yeah.
Right. What is it? It's like a 5x something like all-cause mortality that if you're like engaged in regular exercise, it's like you're 5 times less likely to die. Right. That's pretty good.
It
right?
could be. Yeah. I don't know.
I don't know. And
I don't know how to. I don't know.
Producer Ian shaking his head as hard as he can.
Is he saying yes or no?
He's saying yes
to that.
7 times.
Seven
it's 7x more time. So
and what's the causality? Yeah, and
so
what's and obviously you can look at science. Well, probably some percentage of people when they start getting sick, they don't feel like exercising, and so that kind of confounds the data somewhat. But no, it's a good thing to do. It's a good thing to do.
So when one thing I would ask too, so like the skeptics would say, okay, well, so we're trying things out, but like this is my brain and this is my body, and you're putting chemicals in there, they're going to like alter the levels of chemicals in there. So safety profile and this kind of stuff, as a psychiatrist, like you're comfortable with that trial and error. You're comfortable when you prescribe these things that if they're not in that 33%, like they're going to be okay to get to that next like try, right? Like Lexapro is not going to take you out, and you know what I mean, or so.
Well, yes, and it's and it's complicated, and with some people, it's not. The other thing when you're talking about treating depression is you get some not that small number of people on a global level that are killing themselves based on how they're feeling, and
that can go up with antidepressant use sometimes, right? Or is that
That is debatable in adults. It does seem like kids and young adults have a statistically significant increase in suicidal thinking, but not suicidal behaviors based on starting antidepressant medication.
So there may be some thoughts that are scary, but they're less likely to act on that.
Well, or equally likely to act on it, but not worse. We don't have, when you actually look at like what's the scientific basis in terms of suicide and medications, we don't have that many medicines that have a robust signal for anti-suicidal properties. One of them that we'll probably talk about more at length at some other time is lithium, which is actually an element, which is kind of cool.
That you go on my batteries? Like,
yeah.
Same stuff?
I believe.
Can I just eat a battery?
I would not recommend. I wouldn't recommend you eat a battery.
Different mode of delivery.
And probably a much
that's
lower
amazing.
dose.
So
But so why is that? That on a population basis, that actually markedly lowers the risk of suicidal behaviors and completed suicides amongst populations taking it. I don't think it always affects suicidal thinking, but it does tend to affect suicidal behavior. So that black box warning for antidepressant medications is something you have to talk about when you're starting a minor on an antidepressant with their consent and their parents' consent, or a young adult. It's something you have to be aware about and you have to talk about. That said, we also know that one of the drivers of suicidal behavior is depression. Oftentimes, and antidepressants do often treat depression successfully. And so if you're in that third of people who has a beautiful response to an antidepressant medication, that's for them, that's going to definitely decrease their risk of suicide. But for the third in the middle, I don't know how that plays out based on their psychology and their perceptions about it. And for the third that have a poor response, they might feel more dejected, nothing will help me, more hopeless. And so that has to be talked about and discussed and has to be part of the treatment. And that's part of why we talk about suicide when people come see us for depression, both if they're looking for help with medication or if they're looking for help with therapy or both. So that we do our best to talk about it, to ask about it. And so if somebody is in a place where they're at acute risk of they're thinking a lot about suicide, they have a plan, they have a degree of intent there is a role for inpatient treatment where they need to be in a safe setting with restricted access to means.
Well, and we talked earlier about combined services, and one thing that I would say, and I would sort of kind of even talk directly to the camera, is if somebody or somebody you love is initiating antidepressants or any psychotropic medication, keep them in therapy. Keep a regular contact with your therapist, if nothing else, for sort of the prophylactic and early detection of these changes in behavior.
Of course.
I mean, and we ask about that, and it's so funny because client choice, and we certainly honor that, and everybody has the choice of their own treatment protocols. But this idea of, I see a psychiatrist once a month, he adjusts my medication. I mean, that's 10 to 15 minutes, 30 minutes, that's not enough. You need to be in there processing, if nothing else, from a safety standpoint. So this whole debate, I get sort of passionate about this idea of like, well, can I just do both? Do both for that very reason.
Do both and why? Again, while there is a black box component that we talked about, people get frustrated about, there is there is good data to support that antidepressant medication plus psychotherapy together, on average, do bring a greater percentage of people to remission, meaning that it helps a greater percentage of people not feel depressed. And you're right, from a safety perspective, added touches, added support helps. And
diet and exercise.
Yeah, and along those same lines, like in Ohio, we're doing this quite a lot. Not as much yet in New Hampshire, but we'll do more as we get into more dual diagnosis treatment. But there's a role for case management too, in terms of just having another person to check in with you and check on you and see how you're doing, and then. Also, that's then a whole nother avenue that they can be an on-the-grounds coach to help you with your actual life, to intervene and actually help you, actually go with you to fill out the application for your apartment or for your job, to actually coach you through how to handle these different things, of course.
Go shopping. I've got to get, so Donna Stolas is our director of case management. I've got to get her on. I just think the role of case management is really poorly understood, and it's so vital. And I think, I don't have a direct study to show, but I bet you if we stratified our outcomes, a lot of those clients who are doing the very best in terms of progress have an active relationship with their case manager and have engaged in those services. It's such a key component. New Hampshire, there's some limitations on how that's offered. And I think one of the things that I've learned since being with this organization and interacting more with that case management model is that is a real loss to our clients in terms of depriving them from that case management aspect. So with all that, so that's a fabulous background, and totally appreciate everything you've given us in terms of the background on that. While we were talking about the antidepressant use with the increase in suicide risk, just to throw a confound in there as well. When these articles that I was pulling, and we'll go through them now, we usually started through them before, but I needed that background because some of the terminology in here I felt like we might get lost. But it says in here that in South Korea, where antidepressant use is the lowest among the countries they're analyzing the study, right? So they took a look at, there's this OECD, which is the Organization for Economic Cooperation and Development study, and they looked at antidepressant use in 25 countries over the last 10 years. And you'd probably be floored to hear this, but the use is going through the roof and more and more and more. But what they found in terms of the suicide risk especially was in South Korea, where the antidepressant use is actually very low, one of the lowest in the countries analyzed. Their suicide rate is actually the highest in the developed world.
Really?
Right? And so people are kind of walking around going, well, we're scared of this. I don't know what the effect would be of if I get on antidepressant, maybe my suicide risk ticks up, especially if I'm doing these secondary services. But certainly better than no treatment, right? Because they're not utilizing antidepressants like other people. And this is not to say everybody should be on them. It's highly individualized. But in a country that's not using them at all, their suicide rate is the highest in the developed world.
That's really interesting. It's probably pretty scary being next to North Korea too.
Environmental
stressors. So there's probably a lot of things that go into that data, but it is interesting. And I would say from the data would suggest that the people under 24 have a slight increased risk of suicidal thinking, but not attempts or behavior on antidepressants. People 24 to 65, no difference in terms of it is not shown to increase suicidal thinking. And in people over 65, antidepressants have been shown to decrease suicidal thinking.
Okay.
So
after
there's
young
some
adulthood
there's
and
some
childhood.
age difference. So if you're an adult, I wouldn't worry about that. And even if you're a child or you're a parent of a child, I would not be afraid to try an antidepressant in a safe, supportive environment with open communication. But it's just you're going to have to be able to talk to your adolescent. And then the whole other question that's quite interesting that we actually don't know the answer is what's going on in that small percentage of kiddos that have an increased risk of suicidal thinking with antidepressant. Probably a certain percentage of those will end up on the bipolar spectrum. So we'll find out, okay, so we're not actually treating major depressive disorder. They have a different illness that responds to different medications and different therapy. It's also because it has such a strong anti-anxiety effect. Anxiety, as much as it's very uncomfortable and we don't like it, it is protective. That will keep people from hurt. Yes. So you can get a percentage of people that, if they've been having these kind of dark thoughts, but they've been in kind of the recesses of their brain kicking around, and they've been terrified to think about it. Well, all of a sudden you put them on a medication that reduces their anxiety. Some things can start to pop up. That
they can stare into the abyss, and the abyss will stare back.
Yeah. And I mean, another classical kind of disinhibiting, very strong acute anti-anxiety. Long term, there's a rebound effect, and it makes people more anxious. But alcohol, classic. You get people that increased suicidal thinking, increased suicide risk of suicide attempts and behavior with alcohol consumption, especially heavier alcohol consumption, and in part being profound reduction in anxiety with marked disinhibition of the frontal lobe. And so it's like you kind of kind of forcibly takes the hands off the wheel, and you get people that don't do good with alcohol.
Right. It also makes people good at dancing, really good.
Or at least they feel like they are.
Right off the bat. But so when you're talking about that, the overlay of that, right? So if somebody's on an antidepressant, should they have any fears about alcohol use, marijuana use, other substances? I mean, how do those play together?
Well,
not that we're advocating for that use at all, but if you are,
I think the formal part would be talk to your doctor about it. Talk to who's ever prescribing about it.
Talk to your dealer. I mean, you're right, because that's who they're going to talk to, right?
Yeah. Don't just talk to your dealer. You want to minimize your use. It is permissible to continue responsible alcohol consumption while you're on an antidepressant, but
glass of wine with dinner,
on average,
fine.
it's gonna hit you stronger. So just be aware. So if you're starting an antidepressant and you go out and have a drink or two, that's gonna feel like 2 or 4.
Why does it hit you stronger?
I don't know.
We don't know.
I don't know what. Maybe someone knows. Yeah. I don't know why, but it does tend to hit people harder. So.
I wonder if it was like the excess of you said the serotonin reuptake inhibition. Yeah. If there's extra fuel to go around, you know what I mean? And I don't
know. Or if it's impacting the metabolism through the liver or what's happening. But on average, people are going to be a little bit of a lighter weight drinker, and also if you've gotten to the point that you have clinically really significant anxiety and depression, you're probably better off not drinking or smoking cannabis. In the states where it's legal, such as our neighbor here, Massachusetts, and it probably will be legal everywhere before too long. I just would view those things more as the occasional recreation or social lubricant rather than a treatment. I don't think they're tend to be, best avoided probably.
Well, and sets us on the table with the legalization conversation. Something I hear from clients a lot is that I don't need to take any type of antidepressants because actually I just smoke marijuana to deal with my depression or to deal with my anxiety. That's my medicine. I'll hear that a lot.
Yeah.
Is there any? We don't support that obviously, but is there any reality to what they're saying? Is there any validity to that approach?
Well. There's probably some validity for individuals. That's their felt experience. I don't want to argue about it.
Side, right?
For some people, it depends. There's a lot of difference when we talk about marijuana. Like it's one thing. There are a lot of different plants that are cannabis, and they have
like a lot of different
properties. Yeah. And so, probably some have more medicinal properties than others. Yeah. Certainly, some people tend to get worse with respect to anxiety and depression with cannabis. I don't know that it's a reliable dose response thing like an antidepressant that's been studied, but there are probably some people that get benefit for their symptoms. But I would view when people are talking about their marijuana being their medication, I would say that they should feel just as comfortable talking about their beer being their medication or their vodka being their medication. And there probably are people for whom that
in the short term,
or even long term. You hear about people that have one stiff drink before bed, and it seems to take care of their worries, and they're fine. So I don't want to take that away from the people that are able to use responsibly. I think any drug with a penchant for abuse, there tends to be this whole addiction mindset. The more, it can be hard for people to actually be responsible with it. And certainly with alcohol, in any case, there can be overall rebound of depressive effects and anxiety effects that, but if you're wasted all the time, you're probably not that anxious while you're wasted, but nor are you functional. And there's a host of other health problems that go with it. And so I think that probably over time we'll be able to get somewhat more nuanced with marijuana. There is at least some data, a little bit of data that maybe the CBD is a little bit safer than the THC. Maybe there will be more of a role for that in terms of the treatment of anxiety disorders. But it's a complex plant. There's a lot of other chemicals that are there. There are probably other ones, so over time.
By the time it gets to you, you don't even know, right? Especially with some of the like adulteration, like, they're putting other chemicals in there. They're intentionally putting stronger drugs in there. And now with fentanyl floating around too, on top of everything else, it's like,
I would advise caution, but nor do I want to say, oh my God, never smoke cannabis, never have a beer. I mean, I'm not in that camp.
But how does it function? What's your relationship with it, right? That's a different thing.
And I think I would just be cautious about it, and any substance of abuse, and have kind of kick in that whole addictive mindset and craving and overarching personality. And so,
but if I'm doing that, and I'm doing it responsibly or whatever, and I'm taking Lexapro, like the Lexapro will work.
Yes.
The way it's supposed to work. It's not like it will like cancel it out, or it won't like reduce its effect, or it won't like.
It's a different mechanism of action. It depends on how much you're doing and what, but no, it's not like a direct anti-effect. I've heard alcohol described as like kind of a paint splatter of neurohormones, neuropeptides, and psychoactive substances in your brain. When you drink, a lot of things end up getting leached out in your brain, and so a lot of things happen. It's a blunt instrument. Gotcha. But I'm not trying to knock the people that are getting some benefit from responsible use. That's fine. I mean, likewise, especially in the states where it's legal, I'm not trying to knock the people that get some benefit from a different strain of cannabis that they're able to use a small amount. But I would say that, for every patient that comes to me that seems to have had a profound benefit from cannabis or alcohol, I would say there's probably another 5 to 10 that do it all day long, and they say it's their medicine and helping them, but good Lord, they don't feel good, and they're coming to talk to me about how depressed they are and how anxious they are. So I think that for them, I think there's this,
also the rates of addiction on top of that.
It's just, it's just that for those people, it would be hard to make the argument. They might say it's my medicine, but this certainly doesn't seem like it's working very well for them. But I think but it's very important to honor people's individual lived experience, who they are. This is where we talk with people. So you don't want to make broad judgments and firm conclusions about what something will do for an individual. But I'd say certainly general recommend, keep it legal. Stay within the law. We don't need legal problems. And then if you are in a place where alcohol and or marijuana is legal, then I'd say keep it moderate and be sensible about it. Like with everything. I mean, if you find you're needing to take more and more and more or something to get a perceived benefit, then that's not really helping you the way we would want it to help you.
Sure. And fostering dependency, right? Like I talk with my patients a lot about this idea of need versus want, right? And there's a difference between like, hey, I want a cold beer after, at the end of the work week. That's a want. I need to have this beer or I cannot function around my family. Well, I have a different relationship with that substance, right? And so is this a need issue or is this a want issue? If it's a want, and of course you can play word games all day, like, well, no, I just want it. Like, okay, well, how would you be without it?
That's probably, there's probably a bit of a slippery slope between those things, especially with substances that we know can cause addiction.
They started out as wants, mostly, No one needed heroin before they tried heroin and became physically and psychologically
and
addicted.
If you say, well, I don't need it, I just feel like crap if I don't do it. Well, it's probably shifted into need at that point.
No doubt. What's the old joke? I don't need cocaine. I just like the way it smells. Who was that? Was that Richard Pryor or something? That was hilarious. But so back to the antidepressant stuff. So it's funny. I pulled 2 articles to talk about that, and one thing that jumps off the page to me. So one is from Harvard Health Publishing, and the other is this OECD report. And both of them use some pretty strong language. So the Harvard Health article says there's an astounding increase in antidepressant use by Americans. And the OECD report says something startling is going on with antidepressant use around the world. So maybe that's just journalistic integrity, but just some really emotionally charged language.
I think it's journalistic integrity. I mean, yeah.
You haven't seen that? You don't feel
that? Even if we peel it back to just say, well, a third of people get all the way better, a third of people get a fair amount of benefit, and a third of people don't get benefit, I think we're increasingly as a society in many places saying, well, who are we to take away someone's right? They should get to try that if they're especially the other thing that's really cool about the SSRIs is they don't have they're not substances of abuse. Right. You don't get high. There's not a euphoric benefit if you take more and more and more. You'll just feel sick. So they're not substances of abuse. So they don't have that liability. And you still got 2 out of 3 people that are either going to feel way better on them or get a fair amount better on them. And so I think a lot of people are just saying, I think it's okay.
Maybe it's good they're increasing because more people are getting help.
More people are getting help. Of course, then are there just more people that are depressed and anxious too? And that could be concerning. And I think that could be there. And you could look at, psychosocial stressors.
Pandemic.
You
live next to North Korea. I mean, different things like that.
All sorts of different life stressors. Everybody now, I don't know how to put my finger on it, and so I'm speaking more from like a personal opinion place than from like a hard data. But I gotta think there's something to us being on our screens all the time and getting access to all this news, which is for the most part the way news media makes their money is by people clicking on it and reading it and then seeing the ads. The way they get people to click on it is they say things that are sensational. They take out the context. They make it extreme. So we've got a lot of people that are walking around now plugged into disaster news all around the world. And,
if you're coming from that frame and you're ingesting 75% negative,
you're taking in a lot, or probably, and it's probably more than 75%. It's probably like 95%. And so I don't really know if like genuinely like the human experience is much more stressful on average today than it used to be. My guess would be probably it's not. I'm sure there are individual differences. For some people it is, for some people it's not. But I do think the way in which we're all plugged into a constant media stream of high anxiety, contagion effects of a lot of these emotions, we're wired to connect with one another. You ingest media that's primed to get you angry, scared.
Click, learn more. Yeah.
And many of us are really not in a position where we can do much with that news. So there then is this kind of hopelessness that goes to it in terms of the conversations that I've had with my own 14-year-old son about how upset he is about global warming. Mm-hmm. Upsetting, undoubtedly upsetting. It's also like the media stream and everybody almost says like, all this stuff's so upsetting. You have to be at a 10 out of 10 upset all the time, or you're not a good person, or you're insensitive, or you're not. But that's not healthy. We then have people having their HPA axis and their stress hormones at a maximum setting, engaged in topics that they can't do much with. That's going to drive an increase in depressive illness. It's going to drive an increase in post-traumatic stress disorder. It's going to drive an increase in anxiety disorders. Now, I do follow the news somewhat too. I'm tuned in. It's not like I'm like judging, saying, oh, don't do this. But it does seem like both with adults and with kids who are much less even able to process these things, it's just not healthy. Whereas maybe with an adult reads about a new global warming thing, they get somewhat upset. Maybe it then connects to a behavioral change that they make. And so maybe when they buy their next car, they buy an electric car, or maybe they decide not to run their air conditioner. Then even though it's small, they can say, I've done something as an individual to help address this. And then they can contextualize that in their mind, and they can say, well, at least I'm doing what I can do here. And then they can feel okay. As opposed to, I feel like Mita right now is just saying, basically constantly saying, you should feel like shit now all the time. Well, that's not healthy. Now, I don't know what the answer is in terms of like.
I was going to ask, do you ask your clients to unplug as best they can?
Sometimes, but I often don't even touch that. I probably should more.
They don't. I try.
They don't.
They just don't. How can you? It's almost you could do less, right? But it's like a functional thing. It's so intertwined with what day-to-day life looks like nowadays that I feel like sometimes I'm asking them to not use their right arm. You know what I mean? It's like, don't get on your phone.
It is, but it's definitely has people pumped into the fight, flight, freeze response all the time. It's definitely unhealthy. How best to detangle that, I don't know, but I do think I could say that and I like my smartphone. I'm addicted to it.
Yeah, it's right there.
It's right there. I have it. I do think if we didn't have smartphones, we would probably have less of an increase in depression and anxiety as a world. I don't think these screens have been good for people.
We should turn them off.
I know. Now,
we should turn the internet off.
Good
we
Lord.
Can't, right? Other than this podcast, let's turn the internet off.
But it does seem inconceivable to do that. And so maybe another way to look at it is, how can we help people live better with these new tools? How can we have people, one thing that I will talk about, especially with kids, I will talk about with kids fairly regularly, is turning off past a certain hour at night. That's good for adults too. Now, mind you, I don't want anyone to tell me what to do. If somebody told me to turn off my phone after 8 p.m., I don't.
Even if we told you you're a bad person if you don't?
Okay, I don't know that I would do it, but I do think also we'd probably be healthier if we did and put more parameters around. The other thing where you see this is especially with kids, but it's probably affects adults too, but it used to be that if you had, knock on wood, a lot of people have very difficult home life situations. There's a lot of people that live in traumatic environments. So there are people for whom home is not safe. There are a lot of people for whom home is safe, or it should be safe. But because they're constantly on their devices, it doesn't feel safe, and nowhere feels safe. And with kids, this connects in, especially with bullying, where it's we classically would have used to have to deal with some bullying to differing degrees when we went to school. But
you get home.
You get a place that's safe.
Get on your bike.
You get a place that's safe.
Yeah.
Again, there have always been some people for whom they didn't have that safe zone. Of course, that's awful. But there are a lot of people for whom home should be a safe zone, but it's not, because they get home and they're on all the different social media networks, and so they're still just as connected with that network of people that are bullying and being bullied. I'm sure there's a lot of wonderful connections too, but but they're also not able to deconnect, and so that is probably a driver of adolescent completed suicides. Is they're not able to disconnect from this bullying environment. People that are bullying are able to continue that and get people in their home setting, and so people don't have a break, and so then they can feel more desperate, like they don't have a break, where someone else might have had a tough time at school, but they had a safe zone at home. They can at least recharge, they can rest, they can
which helps your resiliency. You're ready to deal with it the next week.
At least their HPA axis gets to turn off. Yeah. It gets to reset. The stress hormones get to come down. They get to be away from things. They get to reset. And then also that probably allows them to head in and handle it better. They have a new strategy, a new way to handle things, as opposed to being at 10 out of 10 on their anxiety, and then they're stuck there.
Well, not to mention the comparative game that happens too, and this happens with adults a lot, but you go through people's Instagram feeds or Facebook and everybody's smiling, everybody's on vacation, everybody just got a new blank, everybody had a new accomplishment, they're in their, a great outfit, and you watch it long enough and you think that's how everybody else's life looks all day, every
awful.
day. And you're like, dude, my life sucks.
Hey, man.
My life sucks because of this. I'm not on vacation.
And the thing is, because we're the same people in the same environment, maybe even more stressful than it used to be, and it's not a negative thing that when Buddha would say life is suffering, that doesn't mean things are all bad. We could talk about that at length, but many people suffer a lot of the times. Life is hard, and yes, it does not help to see everybody else appear like they don't have problems. There's probably a part of the reason why I have intentionally not engaged myself with social media. Like I learned the other day, LinkedIn is a big thing. Apparently, as a person getting into business, you're really supposed to have a LinkedIn account, and I don't yet. And probably I will, because it's like a thing you're supposed to have. But it's just yet another avenue where which those things get combined. I had a professor, a psychologist, a PhD psychologist in Vermont, Lee Rosen, that maybe he'd be a good guy to have on someday. He's wonderful. And I remember he had a quote once about that, and he said at this point in his life, he and his wife decided they don't have time for people without problems.
That's funny.
Like they've cut those people out of their life because, who wants to just look at people pretending that things are perfect all the time? That's awful. And I've made a connection, choice to cut myself off from that. But I mean, I don't know if that's right or wrong or good or bad.
I've done the same.
You certainly could imagine social media, social networks being more of a place where everybody's sharing their struggles and everybody's processing. Boy, I had two beers too many last night. Gosh, that sucked. And then I got in an argument with my teen son and didn't go so well. Who's had that happen? How do you guys deal with it?
Yeah.
Could you imagine?
Community.
Could you imagine that there being a real life community that actually helps people? Yes, I can imagine that. It doesn't seem like that's what social media for the most part is today.
So I wonder, not to venture too far off the path here, but I wonder if that's not some of the value in things like 12-step, where they talk about we come together, we share our stories. And if you've sat into a 12-step meeting or attended on multiple occasions, it's certainly not a glamorous experience, right? People are not, you may have people who are trying to kind of get some hope and get some strength and kind of talk themselves into the recovery where they're like, oh, I've been clean for a week and life is opening up to me. And some of the old timers will kind of sniff that out and be like, all right, a little bit of, but the vast majority of it is this week sucked in the following ways. And here's what I did to deal with it. And, I'm still sober. I'm hanging in there, but I'm still sober. And the story leading up to it was not all sunshine and rainbows. It was like difficulty. And then there's that companionship where you'll see people that meet after the meeting and go, hey man, I've been there. This is what I do, that kind of stuff.
I'm a big proponent of AA and recovery community. I think it helps people. Yeah. I think it does feel like a genuine community in that sense. I'm sure, it's not perfect. Nothing's perfect, but I do think it's a real source of support for people, and it's definitely something that I encourage my patients to engage in. And it was something that they had me do as part of my psychiatry residency. I got to go to several AA meetings in Vermont where they welcomed me. I got to tell you, you feel kind of like a turd when they go around and everyone's like, my name's so-and-so and I'm an alcoholic.
I've been there.
And then it gets to you and you're like, my name's Mike and maybe I sometimes drink too much, but I'm not an alcoholic. I'm actually I'm a psychiatry resident. Can I stay? And then it's like, oh, and they had to talk. They had to decide if I would be allowed as a but they decided I could. Yeah. And I thought it was lovely. I thought, this is good. I think that's a good source of community for people. I think religion, when it's good, can be a good source of community for people. Seems like in a lot of cases it gets weird or gets radicalized in all different directions. But when it is good, I think it's really good. And AA, when it is often a really good community for people, I think it's a good thing. And I would like to see more of social media veer in that direction. Yeah. And what it would be cool to see is, because it would require a long-term investment. So if we get one of those billionaires that's trying to do good deeds, like that gentleman Mark Cuban, who I've never met. I really don't know much about him or his life story, and so don't say I'm like a pro Cuban guy if he's done bad things. I don't know a lot about him, but I know that he's been trying to invest in creating a pharmacy for the same idea to kind of get people their medications prices down to help people. It's almost like social media needs someone like that. The Facebook guy, Zuckerberg, brilliant guy. Again, another guy I don't know a lot about, so I don't want to get into, he's pro Mark Zuckerberg or anti-Mark Zuckerberg. He did this one bad thing. How could you? I don't know. Yeah. But it would almost require like a huge investment for a social media behemoth to say this is going to be the social media platform where people talk about their problems and are real. Because I feel for a while it's not going to do very well, because it doesn't have that shiny click thing. However, like AA, if it could get through that initial growth hurdle, I could see it being successful because there's other people that are saying, you know what, I'm tired of just trying to post on Facebook about how my life's perfect. That's worthless to me. I want to connect with people on a deeper level. There's probably a way social media platforms could do a much better job with that. And I think that if they had financial backing to kind of ride out that initial rockiness, they could do really well.
Sure. It'd be an interesting thing to be part of.
Right?
It'd have value.
Yeah.
Versus now creating value for the people who are running it.
There's our new...
There it is, a sober space.
Yeah. And I thought about that too for like kind of mental illness in general, almost like we need an AA for mental illness. And then it's almost like you peel back, almost like people need an AA just for life, just a connection and like this is real. And
well, you speak about that real quick to kind of drag us back on the path here really fast. When you say for life, so I read something in there that a certain percentage of people who reported being on the antidepressants had been on for like 10 years or more. So if somebody is, entering into this, I mean, are they signing up for a life sentence of this? Is there a combination where you can take it for a while and then get better behind that? Like what's typical? And
it varies a lot based on the person and what works for them. I think for depressive illness in particular, there's often a role of using the antidepressant for a period of 3 to 6 months, 6 to 9 months, and then you can taper off of it and use it again if needed. For anxiety disorders, it depends on more like your level of anxiety that you're comfortable tolerating. I mean, we all have different anxiety set points. It's evolutionarily wired in. It's meant to be that way. It's wired in that way. It's that way even in fish. It's that way in guppies. So when, a fish, it's designed to roughly be evenly distributed between the guppies that are terrified and basically hide in the rocks all the time and kind of sneak out to eat a little bit, and a third of the guppies that kind of get out a little bit, and then a third of the guppies that are like the free-spirited, like, woohoo, they're right about. And you can think about, and that's actually, so there's that different anxiety set points for fish. It extends up through all the different animals. And so, and evolutionarily, it's because when times are good, the guppies that are out being wild and eating a lot of food and making a lot of guppy babies, they do very well. The guppies that are kind of in the middle do okay. And when times are good, the guppies that are just scraping by in the rocks don't do so hot, Yeah. However, periodically a predator comes along and eats all the happy-go-lucky guppies. Okay, and then the guppies that were hiding among the rocks survive, endure, and then they're able to have children, and then their children break down roughly the same way in terms of a third are happy-go-lucky, a third are, and so there's a real core survival advantage to having variable anxiety functions for people. There's a lot of other things you could do to manage that, but say you're one of the guppies in the rocks. Yeah. All right, so your anxiety set point is just very, very high. Well, you get to decide, to some degree, especially if you're one of those guppies amongst the rocks, who is one of the third that responds brilliantly to an SSRI, and you take your Lexapro and you feel good and you don't feel overly anxious. I think you'd work with your doctor, you work with your therapist, and that's your choice. There are some people for whom those medications continue to work beautifully well indefinitely. Yeah. There are some percentage of people for whom they seem to work for a few years to a decade and then seem to peter out and not work so good for whatever reason. And then there are people for whom, they just want to use that when things are really bad, but they don't really want to take it forever.
Does it work that way though? Can you plug it in and plug it out? I mean, aren't you supposed to take it over time to like, I hear about this, like the levels building up.
Well, you can
depend on the medication.
You can plug it in and plug it out, but the effects that you're getting tend to be weeks to months out. So you want to look at a longer time spectrum of time.
Cycle kind of thing.
Yeah. So there are plenty of people that will take antidepressants for 6 months or 9 months or a year, and then they won't for maybe forever, or they won't for a couple years, and then for whatever reason, life conspires. As we mentioned, life is tough. Different things pile up. Maybe they get behind on their self-care. They're not exercising anymore. They're not eating well. Lo and behold, they're depressed and anxious, and they're really struggling to get out of bed in the morning. Then they can go on an antidepressant and get that same positive response. And then so is it a life sentence? No. But it depends on the person. But I also don't want to make it sound negative for the person who's doing beautifully well on the antidepressant and they want to stay on it, then who's to tell them that they shouldn't, or that there's something moral about it? That's the other thing that we'll talk about over time here, more kind of the weaving in of the morality into, or ideas of morality into treatment, which is, it can probably on the whole is not very helpful for treatment. But I'd say for people that are thinking about it, no. I mean, it's a free country, and certainly plenty of people get prescribed medications and don't take them, or tell their doctor they are and they don't take them. That's a whole other thing. Yeah, add it to the rest of us. But it's variable. Yeah. It's variable.
It is interesting. And the morality piece of it too, like you hear that a lot of times of like, well, I'm just swapping addictions, or if I took this to feel a certain way, what's the difference between that to make me feel a different way? And so it's just all resistant stuff, you know.
You know, and you got to work with where people are at on that. And so there's a huge role for individual preference, their thought process, how they process things. My bias or my thought process as a psychiatrist, I tend to be more functional, kind of looking at the overall how somebody's doing in their life, how they're feeling in their life, how they're doing with their relationships, work, how they're feeling about themselves. I tend to have a functional bias towards wanting people to have high level of functionality that then they feel good. But, you know, that's my bias. So it's not, but maybe that's more than a bias. That's my role as a doctor. If you're coming to me, I'm trying to help you feel better. So what I would say with, well, why are you swapping one addiction for the other? If you're saying, well, you know, before I was drinking all the time, it's just it's a functionality thing. I mean, alcohol doesn't work as well.
That was not working for you.
It doesn't work very well. So functionally, it's just not giving you the effect that you need. And if you are one of the people that feel really good when you're drinking, but it impacts your other functionality. You can't drive. You lose your job. There's other aspects of things that it causes a lot of problems. Whereas the antidepressants for most people, especially if they don't have bipolar disorder, tend to help a lot with the functional component of things. And so, you know, I don't know, but I know what you mean. The idea of, but it's like everything we do has neurochemical effects. You could say, well, exercise has powerful neurochemical effects on the brain. So if you exercise every day, or you're really just an addict, and
right, you could make that case for anything.
You can make that case for anything, and so
there's a consistency problem too, right? Where like, I don't want to put these foreign substances in my body. Now, excuse me, I'm going to go eat McDonald's for lunch. You know what I mean? And the ingredient list and that kind of stuff. And so there's a consistency piece to it. But I think when I hear that as a therapist, it's not so much a black and white argument about like, well, this, and it's an expression of fear a little bit sometimes, or anxiety, or lack of education. If you knew more, you'd be more comfortable with your decision, right? So to me, it's not to go in there and like arm wrestle you over the resistance. It's like, well, okay, so what would it look like if you felt a little bit better? What would you need to hear to feel a little bit better about it? Well, if I knew exactly what was in this stuff, great. Let's take a look. You know, here's the fact sheet. Here's the data sheet. Let's look what goes into this. Let's look at resources like this. Let's let you have a conversation with Dr. Boggs about what it's going to actually do for you.
And it's different for different people, and it's all, people get to make their own decisions, and then you work to help people in ways that they're willing to be helped. So if somebody's is depressed and they're not willing to take an antidepressant medication, but they're willing to talk to a therapist once a week, well, that's a great start. And it could be sufficient. If they're not willing to seek a mental health professional at all, but they are willing to make a commitment to go to the gym for an hour every day, and they're willing to improve their diet to make sure they're getting fruits and vegetables, and they're willing to do that, then okay, then they're willing to do that. So we can look for the different avenues via people have improved functionality and meaning and fulfillment in their lives, and we can go with that.
Amazing. Amazing. I could talk about this stuff all day. I've talked about this stuff for years. I appreciate you making the time. You're going to be back. We're going to do a lot of these. I learned something. I mean, this is not just sort of fluff. I learned something every time I talk to Dr. Boggs, and I learned that there's nervous fish, which is amazing to learn about. And I want to be a happy-go-lucky guppy. And so the more I can learn about that, but only at the right time, right? Too much of that. Maybe a middle guppy. They seem like they do okay.
Maybe a middle guppy.
A middle guppy seems like it does okay.
Try, and then you want to feel better, but you also want to kind of accept where you're at, because then acceptance, if you accept, is also very powerful, and then you can feel better. You kind of work with where you are. And
that's the Buddha stuff again, the acceptance of the challenges we face and the pain that is some of this sometimes. But what is that comment about, like, pain is guaranteed but suffering is optional, right? So you can have the pain, but your mindset is going to determine whether you suffer because of that or whether you flourish in spite of that. So I appreciate your time very much. So we'll wrap here. I mean, is there anything else that you would want to offer, or anybody who's thinking about it, just get an assessment, right? Ask somebody.
If you need help, get help. If you're not sure if you need help, reach out and get help and see. That don't hesitate to reach out. Life can be hard, and there is good help out there. And
nobody really resists a blood test to rule out an issue. And I think that's sort of the scary part about psychiatrists and talking to them is like, oh, I'm going to get, maybe not. Maybe you're going to talk with psychiatrists and realize, this can be managed through behavioral avenues, or we can try some other things first. It doesn't mean it's more of a learning experience.
It's always different
else.
options, and it's your body, and you get to decide. So this is not, you're not. Don't let anybody make you do anything. You just get. But if you're suffering, then get help.
Yeah. Life is too long and too short at the same time to have to feel like that every single day. So that's great. Okay, well we'll wrap there. Again, appreciate you coming by. Looking forward to the next one. Through Helping Back. No more difference that makes a difference. Although it's in there, it's in the background. But this makes for an easier website. This makes for an easier find. And so this sounds great. So again, this whole entire operation here is sponsored by A New Behavioral Health. If you or a loved one is seeking help, especially if you're in Ohio or New Hampshire, go to ANEWBH, so anewbh.com. You can also find us on Instagram. You can find us on Facebook. Always happy to hear your story, always happy to get the background. And if we have services that can make life a little bit better, we're happy to help. And if not, that's a great thing to know too. And if we can't help you, we can certainly get you connected with somebody who can. So thanks again, Dr. Boggs. Appreciate your time.
Thank you, Jason. Appreciate your time.
Yeah. And until next time, take care of yourself first and foremost. And while you're at it, take care of each other. Take care.
All right. Cheers, Jason.
All right.